Good afternoon, esteemed colleagues. Thank you very much for having me here. Thank you for the privilege to be able to speak to you guys here. It's very hard to follow the suit with such amazing talks, so I'm going to try to keep it limited. A lot of things have already been said, Greek philosophers always sought to understand the world with the word I'll use, logic. And I'll follow the same principles, try to understand what is robotics, when it started, how we are using it today, and where do we see the future going. And throughout the talk, I'll focus on the whys. And a lot of data has already been shared, so I'll try to keep it limited. So the word robot came from over 100 years ago from a Czech playwright, from the word robota in Czech language means forced labor. And when we think of robots, we think of these programmable devices that can execute tasks on their own, independent of any human interaction. So Yang et al., 7-8 years ago, kind of like came up with a classification of kind of give a framework for what the capabilities of a robot are. So level zero is the Da Vinci robot that we use today. Zero autonomy, it's pretty much telesurgery or telemanipulation where surgeons' actions are transferred one-on-one to what happens inside the body to robotic assistant, which may be augmented reality, maybe putting some guardrails or protections around where the surgeon cannot harm the patient, to task and autonomy where robots can perform very limited tasks, repetitive tasks to avoid surgeon fatigue. Moving on to level 3 where the robots have more perceptual capability where it can use real-time data to analyze and maybe do some stuff, perform independent surgery in an unstructured environment. Moving on to level 4, where the robots have access to data from even before the surgery, during surgery, and can devise an interventional plan and execute on its own with supervision. And level 5 would be robotic utopia, where no humans needed. So unfortunately today, the medical robots are level 0 automation. The whole concept of robotic surgery, as alluded earlier, came with scientist Scott Fisher at NASA in the 1960s, came up with this 3D head-mounted display that combined with Joe Rosen was a plastic surgeon trying to do microsurgery with miniature robots, and the combination of the two is what we use today, and the rest is history. This is the very first robot. This was actually taken from a manufacturing industry, and all the robot does is, it's called robot, and that's how it was introduced, is setting the surgeon's hand to do a brain biopsy. Same concept for hip replacements. This is a voice-controlled robotic arm just to hold the camera to avoid and provide a stable image for the surgeon to operate with and avoid lens smudging. This is the very first robot that, again, alluded, named Zeus, aptly named after the king of gods. This is a pig study that was shown to be able to do, this is the first ever documented report that I could find online to be able to do robotic heart surgery. This is how it looked like, and this is what we use today. It has 3 parts. The left side is where the surgeon sits, engages its arms and feet to manipulate the arms, which are on the patient side console, and then the computer sits on the right side there. This is first documented coronary bypass surgery reported by Intuitive System, 2 patients, and that's how the incisions look like. Believe it or not, this is 25 years ago. This is last millennia. So why robotic? So I have 2 joints, in my arm. The robot has 5. And my hand can only move so much. Robot has 6 degrees of freedom. It was designed to mimic a human hand, but I bet it's better than hand. And here's why. The robot there's a lot more dexterity, is more precise. It is 20 times smaller than my hand. The end effector arms have, again, 6 degrees of freedom. And you can scale it such that 10 centimeters of my hand movement would only transfer 1 centimeter movement inside the patient. And it can reduce your tremor. that you can have with long-shafted instruments. And lastly, it allows you to do telesurgery. You don't have to have your hands inside the patient. So just like evolution, some of these slides you guys have already seen, 100 years ago, not being able to offer open heart surgery to the new gold standard of median sternotomy to heart port, and now what I call 4.0 is totally endoscopic surgery. I think that is the future. If heart surgery is to stay relevant in the next 20 years, we have to adopt that. So there are these three surgeries: isolated mitral valve repair, coronary bypass, and aortic valve surgery comprise more than 80% of all heart surgery that we do today anywhere in the world. And this is our set of our mitral valve surgery: 5 incisions, 4 8-millimeter ports, and 1 12-millimeter assistant port. So this is, and I've picked 3 cases. I'm going to show 3 cases. This is the mitral case. This is a 73-year-old lady with bileaflet prolapse. You can see A2, A3, and P2, P3 prolapsing into the atrium. And this is, we're opening the pericardium with the robot. This is a sped up, I don't operate that fast. Dissecting around the aorta, putting an integrate stitch in, and we put the integrate in, we externalize around the assistant port cross clamp, and you can assess, and you can see the dexterity of the robot. You can actually move the camera in and out and go inside the ventricle. So I'm doing the Roman arch repair as popularized by Dr. Kofidis here, and you can actually go down to the papillary head that is relevant to the segment of the leaflet you're repairing. You don't have to, with endoscopic surgery, you're lucky if you get a good bite on the papillary muscle. With this one, you can actually go exactly where you meant to be. So this is P2 repair. You can see your bites are exactly perpendicular. You can lift up. You can see exactly going to the posterior heads of the papillary muscles. You can tie with the robot. And then this is, once we repair the posterior leaflet, you can check the valve. And in this case, the anterior leaflet is also prolapsed. You can see it's coming up into the atrium. And now we are going to the anterior heads of the relevant papillary muscles, going perpendicular, closing all the clefts along the way. You cannot do this operation. Yes, you can do this with endoscopy, but you have to be extremely, extremely skilled. With the robot, even I can do this. This really enables you to be able to do this operation with precision and accuracy, and you'll see the final result in just a second. Deep posterior coaptation, I'll open it up and it's still pressurized. I usually wait 3-5 seconds and then open it, make sure it's still pressurized, and if that looks good, that looks pretty good. 0 leak, really low gradients, no prolapse. And these are the incisions. Operator mortality consistently less than 1% in various studies. There's in fact paper that suggests that there's a higher repair rate with the robotic compared to sternotomy. Reduced ICU stay, hospital stay, return to normal activities is quicker, and then you can return to employment sooner. Now, Cleveland Clinic has done 4,000 robotic mitral surgery with 0 mortality, and there is no reason anybody should not be able to replicate that. This is 10 years ago, meta-analysis that shows there's mortality benefit to doing mitral valve repairs with a robot versus sternotomy. Coronary artery bypass, this picture is 10 years old. We don't do this like this because the subcostal port, unfortunately, we don't have the stabilizer that goes through this port. So we have modified this technique a little bit, but I'll show coronary artery bypass with the robot. We can bring in off-pump stabilizer through a subcostal port and stabilize the left anterior descending artery, and the view is just amazing. And this is how, let me see if I can show you how we set up the outside. Oh, goodness gracious. So this is the port that we use. You can see a glimpse of it. It's a soft tissue retractor that we use to instead of a robotic port. But out of that, otherwise it looks pretty much the same. But you can see the angles. You can be perpendicular to the epicardium. You don't have to use long shafted instruments. Preparing the conduit we harvest in a skeletonized fashion. The exposure is just amazing. And when you have your head inside the console, the coronary artery is the size of this room. So I'll just let the video do the talking. It's a 2-minute video, but there's a 2 millimeter shunt and we use it to prevent ischemia while we're doing our anastomosis. Believe it or not, the Da Vinci robot was originally designed for this operation. You can be perpendicular, the bites are, you can see the equidistant. We forward through a little bit. Don't want to bore you guys with these videos. And you'll see in just a second, you can actually sew with your left hand. And I'm right-handed. So if it's left hand, you can't even tell the difference. Move the shunt. And excellent flows. We check flows in every case. Nice big Cobra hood. So that's TCAP, and these are the incisions that patients go home usually on post-op day 2. Excellent outcomes. University of Chicago has I think a 1500 series. Excellent outcomes at 1 year and long-term outcomes. Very much similar to median sternotomy. There is a big question about the cost of the robot. So this is actually a European study that looked at the upfront costs of the robot are very easily offset by quicker recovery, shorter hospital stay, and whatnot. And there's a study from the US that I did not include that shows that it's actually cheaper to do it with a robot than do a sternotomy. So this is the next frontier, aortic valve surgery. This is our current setup for aortic valve surgery. This was believe it or not, first described 20 years ago, and now is being repopularized by the upcoming president of STS, Dr. Vinay Badwar. So that's how he does it. So this is a patient that is a 46-year-old gentleman that not only had a severe aortic valve stenosis, but also had an aneurysm, as pointed out by the arrow, in his interventricular septum, and was sitting right under the aortic valve. So I thought it would be a good case to do it with a robot. So I'm just going to play through these pictures. You can see the aneurysm is right under the aortic valve, and we will fix this and replace the aortic valve at the same time with the robot. And we got an echo which shows that there's indeed a outpouching right under the aortic valve. So same thing, cross-clamp the aorta, open the aorta. And the best part of the robotic instruments is that you don't have to bring the tissue in line with your long-shafted instruments. You can actually curve in your instruments to the curvature of the annulus. And you can take out a valve in one piece. This is a unicusp valve pretty much. And now you'll see the defect in the interventricular septum. You can see the muscular portion down below. There's a defect right in the commissure between right and non-coronary sinus. So we'll just take a patch and sew it up. And you'll see that I'm sewing with my left hand. It doesn't matter. The robot takes away your tremor, steadies you, and just the angles that you can get to sew would be impossible to get with even open surgery.
Ghulam, I could go on watching the techniques forever. They're so brilliant. I just received message from the control basically that we are running quite late. The day-to-day is unusually well regulated. So may I ask you to try? You are within time limit yet, but
I will be
try
over.
to expedite.
We are on like surgeon time. We say it's going to take 1 hour, but it takes an hour and a half.
Right, right. I hate to do this, Ghulam, particularly you're a brilliant guest.
So I will move along. So we close the aorta, looks great. It's 5 centimeter incision, and if I wasn't doing the aneurysm, I'd probably do 4 or 3 centimeter incision. So this is the largest study on robotic aortic valve. We just presented this at EX. Extremely low complication risk, very comparable to open surgery. The current landscape, we can pretty much do any operation with a robot. The only operation that has not been done so far is aneurysm surgery. there was a transplant just reported a month ago from Saudi Arabia. Robotic mitral valve repair and robotic cardiac surgery is growing. Last year, 20% growth. Just this year, we have already surpassed that. There are more and more mitral valve surgeries being done in the US with a robot. A number of programs that are in line to be waiting to be trained, and these are the total number of programs that are doing robotic mitral valve repairs in the US. So I'll just spend a couple of more minutes on what the future holds. We are just scraping the surface. We are on level 0 right now. Just imagine the possibilities moving forward with today's technology and the processing power we have with the computers today. There are 20 companies right now in market with multi-arm robots that are all level 0 so far. But the outlook is amazing. This is just a very short video of a single port surgery. It's not been used for the hearts quite yet, but there is no reason it shouldn't be. So I'll just move it forward through the video. This is augmented reality. This is a hologram was shown by Dr. Kofidis not too long ago, but you can superimpose imaging over the patient for surgical planning. This is not a cardiac case, but just to proof of concept. And then what's the role of artificial intelligence and machine learning? AI can help us process a lot more information than a human mind can help us decide which surgery would be better for a patient. We can look at long-term outcomes and whatnot and take that into account and analyze what 1 million papers published every year and help us plan our surgeries better. It can help us with precision. You saw 3 videos. It's an amazing tool. And then computer vision. Computer vision can see things that human eyes can, like repairing a mitral valve. You can see a circumflex artery superimposed in an augmented reality fashion, or where the aortic valve is, so you reduce, or AV node for that matter. And then automated suturing. So again, I'm going to let this play.
And markers are then manually applied to the corners of the bowel for robust tissue tracking.
This is for general surgery, but just to see what the computer can do.
STAR's imaging system detects and tracks the anastomosis site, despite soft tissue deformations and breathing artifacts. Furthermore, STAR generates 3-dimensional point clouds of the surgical site and autonomously overlays optimized surgical plans for the anastomosis. When a surgical plan is not consistent with the 3-dimensional point cloud as shown on the front wall of this tissue, the surgeon initiates a replanning algorithm to generate a new point cloud with corresponding surgical plan. STAR creates an anastomosis by first performing a running suture along the back wall of the small bowel. A human assistant removes all loose thread from the surgical field to prevent the formation of locking sutures.
So in the interest of time, I'll move along, but you can see what the robot can do. This has not been done for cardiac surgery yet, but there is no reason it shouldn't be. And I think AI and machine learning can help us not only improve efficiency, but accuracy, and more importantly, going back to access. We can transfer expertise from very experienced surgeons to new surgeons with machines helping them go through the learning curves much quicker and faster. And I'll just finish the talk with we are at the cusp of a golden age for robotic cardiac surgery. We have to embrace this technology to help us become not only better surgeons but better physicians for our patients. Thank you very much.